ureters, on average, in an adult, 25 centimeters long. They propel urine from the kidneys down to the urinary bladder, and now the ureters are narrowed at 3 positions. We shall look at those positions where they are narrowed. But to begin with the histology, the inner lining of the ureters, are you hearing me?
Yes, we can hear you.
The inner lining of the ureter is made up of a transitional epithelium, and I believe you did epithelial tissue in cells and tissues. The inner lining is made up of a transitional epithelium. Then that when we make a cross section through the wall of the ureter, the inner lining is made up of a transitional epithelium sitting on a basement membrane known as the lamina propria. It's mainly made up of collagen. And then it's made up of a smooth muscle, that's the muscular layer. This is the layer which contracts as the ureter is propelling the urine. And then the outer layer is the adventitia. So we are looking at the inner lining, which is the transitional epithelium. The transitional epithelium, which is sitting on a basement membrane, the lamina propria. And then we'll have the muscularis layer, which is made up of the inner longitudinal and the outer circular, and then the outer layer, which is the adventitia. Are we together?
Yes.
Yes, sir.
The inner layer is made up of the transitional epithelium, then the basement membrane, which is the lamina propria. All of these form the mucosa. Then the muscularis layer made up of the inner longitudinal and the outer circular, and the outer layer, which is the adventitia. That's the histology of the ureters. The anterior relations of the ureters. The proximal part will have the second part of the duodenum. Then the middle portion will have these blood vessels crossing anterior to the ureters. The right colic and the iliac. You remember our GIT. The iliac and the right colic supplying the ascending colon in the right lumbar. Then the gonadal vessels. So these branches of the superior mesenteric, the right colic, the iliac, and then the gonadal vessel, which is the testicular ovarian on the right, they pass anterior to the ureter. Then this is the mesentery. This mesentery of the small intestines crosses anterior to them. So these are the anterior relations of the right ureter. It lies posterior to them. That's why the ureter is on the posterior abdominal wall. Then the left, we have the left gonadal vessel, the left colic, a branch of the inferior mesenteric, and the sigmoid branches. These are supplying the descending colon and the sigmoid colon, and then the sigmoid mesocolon, that is the mesentery of the sigmoid colon. These lie anterior to the left ureters. You know, imaging is more about structures and their relations, because when you're scanning that structure of interest, you see those blood vessels and structures crossing anterior to them. Posterior to the right ureter and left ureter, you are going to see this muscle called quadratus lumborum. Quadratus lumborum. Psoas, not quadratus, psoas muscle. This is the psoas muscle, not quadratus, psoas muscle. So this muscle psoas lies posterior to the right and the left ureters. So the posterior relations are the same. The blood supply to the ureters, we have the upper portion is receiving blood supply from the renal artery. The middle portion receives blood supply from the gonadal arteries, testicular or ovarian, depending on the sex. And the inferior portion is receiving blood supply from the superior vesical artery, which is a blood vessel to the urinary bladder. Upper portion a branch from the renal artery. Middle portion, a branch from the gonadal arteries. Lower portion, a branch from the superior vesicle, which is coming from the internal iliac. However, those are the major vessels which supply the ureter predominantly. But you might have minor branches from the aorta and the other vessels of the pelvis. The ureter is narrowed in 3 positions. The ureter is narrowed in 3 positions, and these narrowings can lead to kidney stones lodging there. And when a kidney stone lodges in a portion of the ureter, it blocks the flow of urine. When urine flow is blocked, we are going to see the major calyces widening because the urine which is entering them is not being drained because of a blockage somewhere. So on ultrasound and on imaging modalities, you're going to see the calyces widening, accumulating with urine, a condition known as hydronephrosis. Why? Because there is a blockage somewhere along the flow of the urinary tract. Mainly, it can be a kidney stone which lodges there. It can be a mass which lodges there. So it can be a pregnant woman. As the fetus grows, the fetus can compress the ureters and kind of narrow them such that you have some hydronephrosis in the kidneys. Hydronephrosis is the widening of the calyces and the renal pelvis because of accumulation of urine, and what is causing that is either blockage of the ureters or they are narrowing. So we have the first narrowing is when the renal pelvis is bending to join the ureter. When the renal pelvis is bending to join the ureter, we have the first narrowing or constriction there. And when the ureter is crossing the bifurcation of the common iliac around here, there is a second narrowing here. This is the pelvic brim, the entrance of the pelvis. You see it is passing anterior to the bifurcation of the common iliac. So these common iliac vessels are pulsating, especially the artery, and that pulsation is going to lead to a narrowing there. And the third narrowing is when the ureters are draining into the urinary bladder. That's where you have the third narrowing. The first narrowing at the hilum, when the pelvis is bending to join the ureter. The second, when it is crossing the common iliac blood vessels at their bifurcation of the pelvic brim. And the third, when it is entering into the urinary bladder. And these narrowings, broken tissue can block there, kidney stones can block there, and then it will block the flow of urine. And if urine is blocked, it is going to accumulate in the calyces and they're going to widen out to cause a condition known as hydronephrosis. However, in cases of pregnancy, the developing fetus can also compress this ureter and narrow its lumen, leading also to the temporary hydronephrosis. So the first narrowing at the point where the renal pelvis joins the ureter, the second narrowing when it's crossing the common iliac, and the third narrowing is when it's entering the urinary bladder. So kidney stones can lodge anywhere at those points. And then the urine is going to accumulate here, and these are going to enlarge to cause hydronephrosis. Cancerous tumors can also lead to blockage and other tissues which are dead tissues which have broken off can also lodge there. The principle is that there is a narrowing and any solid can lodge there and prevent the flow of urine. So here we are seeing our kidney cortex, columns of Barton. Here we are seeing the region of the minor calyces, and then we are seeing a stone here, no renal calculi. You can see this is the renal pelvis bending to continue with the ureter. The renal pelvis bending to continue with the ureter. So the more you retain urine, the more it concentrates and the more it can cause these solid structures known as calculi. That's why you're supposed to take so much water so that you do not have concentrated urine, and you must empty your urinary bladder whenever you sense the urge to urinate, because when you take little water, urine is going to be concentrated and then it is going to crystallize. The sodium chloride and other minerals are going to crystallize to form these stones. And when this stone reaches the First constriction, it can lodge there and block the flow of urine. And you're going to be seeing more of those stones in your clinical practice.